be split up. Do you want me to turn it off in between?
Wherever you want.
Or just,
Yep, I got 4 of them set up, so whatever we need to do. All right.
You guys able to pull these up? Chapter 2?
I think it's just chapter 9.
Yeah.
No, it's in
Wait, no, that shouldn't be the same one. Yeah, so this will be this will be a different book.
Yeah.
If you guys want to at some point go over chapter 1. Chapter 1 is just a review of a lot of the basics, stuff that we've talked about in previous lectures that I felt would just be redundant if we did it here. But it is a good review if you guys feel like you need it. All right, let's get these objectives. All right, so the electrocardiogram. So as we've discussed before, the electrocardiogram is, it records electrical potentials, right? So it records the conduction system of the heart and depolarization of that heart muscle, because that all creates a current that the EKG machine picks up. So it can tell us the orientation of the heart. Some people have dextrocardia. Do you guys know what that is? It's flipped, right? So the whole heart would be flipped onto the other side, and you could potentially pick that up on an EKG. Based on, if you set up your leads in the normal standard way, everything should be opposite on the dextrocardia, right? Your deflections, negative and positive deflections, will all be opposite. So you should be able to pick that up. An EKG can tell you a lot of different things. That's why, oftentimes we refer it as, the glucose is a 6th vital sign. You could throw in an EKG in there as well. An EKG can tell you a lot more than just whether or not a patient's having a heart attack or not. They're taking too much or too little of medications, how dehydrated they are. From your guys' perspective, if a patient looks severely dehydrated, you guys can't get a blood test to see where their sodium level is, where their potassium, where their magnesium level is. But an EKG can tell you if it's in dangerous levels. So mass of cardiac muscle. So depending on how long the patient's been dealing with atherosclerosis, hypertension, whatever, if there's more mass, you can pick that up, right? What would that be called on an EKG? Okay, so like LVH, left ventricular hypertrophy, or RVH. All right, and of course, you can pick up ischemia. So one thing that the EKG does not do is it does not pick up the mechanics. So the contractile force of the myocardium. That is something that you can pick up on your vital signs, right? Heart rate, your blood pressure, that tells you how well your contractile force is. Sometimes, if the patient's septic and they're vasodilated, then sometimes it doesn't matter how good the contractile force is, right? You're still not going to get good blood pressure. So indication is to get a 12 lead. Obviously chest pain. And we get probably way too many EKGs, but we should be getting EKGs. It's an easy test. It's a quick test. It can give you a lot of information. I always laugh at triage when they get, a 12 lead EKG on a 16-year-old that got hit in football practice and now is experiencing some discomfort in their chest. But who cares, right? get it anyway. So, you know, any kind of dysrhythmia, obviously you want to get a full 12 lead. You pick up the dysrhythmia on the monitor or on the rhythm strip, but always a good idea to get the 12 lead anyway. Take a look at all the different leads, and it'll give you better information and to figure out what kind of dysrhythmia it is. Ventricle failure, before and after electrical therapy, you know, it's not proven that your shock worked until you have a 12 lead EKG that confirms that. All right. Syncope, near syncope, we obviously get 12 leads for all of those things. Electrical injury, stroke, any kind of unstable patient. Their vital signs look wacky, get a 12 lead. Medication abnormalities, electrolyte abnormalities. So the electrodes. So obviously they're applied at specific locations, right? You're not just throwing them all on, hoping that you'll get a good read. One end is attached to the electrode. The other end is obviously attached to the machine where it can record what's being picked up. So this is a LifePak 12. I know you guys work with 15s, but you are going to have, you know, similar, I guess, buttons. So anytime you're going to get an EKG, obviously, you know, you want to explain to the patient what you're going to be doing. And then you're checking your equipment, making sure that there's no loose pins, that your wires all look good, nothing's frayed or broken. You know, you can obviously turn the monitor on, and you can adjust the contrast. You can adjust the amplitude. You can do that after you hook the patient up too, depending on how you're seeing your amplitude. If it looks too small, you can increase the amplitude on the monitor so you can see more definitive, you know, waveforms and whatnot. Sometimes your amplitude is going to be super small because the patient's huge, either muscularly or fat. All right, so you know, you get your electrodes. You make sure that your gel looks good. You clean the area. You know, obviously that's why we, you know, put a set of pads on a hairy chest and then rip them off and put another set of pads on, because hair will distort both any kind of electrical conduction, recording or giving the electricity. So you want to, you know, try to get the hair off. You want to make sure that the area is clean. It's not too oily. So you prep, make sure that there's going to be good contact with the skin. Remove the backing from each of those sticky sides. Put them on the patient in the appropriate places. You want to make sure that the patient is relaxed, and that, you know, if you're putting them on a limb, that limb isn't, you know, quivering, shaking. Obviously, you won't be able to help that all the time, but you want to try to optimize your situation as best you can. Get the patient to relax, like I said. If your stuff's not already preset, then you can adjust what you're picking up. The leads that you're seeing, amplitude that you're seeing, yada, yada. All right, as you guys know, and I'm glad that you guys are already doing this in our labs, what you're seeing on the monitor isn't always easy to interpret. And oftentimes it'll be easier to interpret on a printout. You'll be able to see your markings and be able to diagnose and decipher that rhythm a lot better if you print it out. You guys know how to do that, right? That print button, right? All right. So your leads. So each lead is recording the current flow from one area to the other, right? So it's from a negative to a positive, depending on what kind of lead it is. We'll talk about that in a little bit. There's unipolar leads and bipolar leads, and which ones are which. And then kind of the view that you have to kind of imagine with this electrical activity. These electrodes record either in a frontal plane or a horizontal plane. Do you guys understand what plane we're talking about when we say frontal or coronal, horizontal or transverse, right? So what would be a coronal plane? Somebody standing up to you, what's the frontal or coronal plane? So it'd be this plane, right? What's a sagittal? And an EKG is not sagittal, but what's sagittal? Sagittal is this way, right? And then a horizontal is going to be this way. So in an EKG, we record frontal plane and then horizontal plane across the heart. All right? So we've talked about this before, you know, as you're looking at a patient or if you're imagining a heart, this is how those leads are set up. Of course, you've got AVR, AVL, and AVF. Those are easy to remember and where they're positioning because it's right, left, and foot, right? Lead 1 is always at that 0 degrees. If you guys can imagine this being 0 to 360, this is at 0, and they're going down to 90, 180, 270, and then back to 0. So you've got lead 1 to the left, lead 2. That's why we always say P waves. You've got your normal kind of deflections of your waveforms that you're going to see in lead 2, because that's generally how your heart is depolarizing, right? Anyway, from that end to that end, that's why lead 2 is so good. So 6 leads in the frontal plane, 3 bipolar and 3 unipolar. Can you guys guess which ones are which? What do you think?
1, 2, and 3 are bipolar.
Good. 1, 2, and 3 are bipolar. AVR, AVL, and AVF is unipolar. All right, so the bipolar leads in the frontal plane. So a bipolar has a negative and a positive electrode, or at least unipolar only has a positive electrode. The bipolar has both, or at least uses both. We'll try to clarify some of that as well. Okay, the unipolar leads, these are, as we talked about, the augmented LEM leads, AVR, AVL, and AVF. Single positive electrode, it's more of a reference point. So your LEM leads, 1, 2, and 3. The right arm electrode is always going to be negative, going towards the positive in the left arm and the left foot. Okay? So if you can imagine that, and that deflection from negative to positive should be a positive deflection, right? So if you have normal conduction going in the direction that normal conduction in the heart should go, then leads that are picking up that direction should have a positive deflection. Does that make sense? All right, so lead 1, that's from the right arm to the left. That's positive deflection. That's why it's at that 0 degrees, because it's straight across. Fuse the lateral wall of the left ventricle. Does that make sense why it would be the lateral wall of the left ventricle? Because the lateral wall of the left ventricle is the furthest or the most left part of the heart, right? So as that depolarization is going down, it's also moving to the left, and you're picking up anything that's going from right to left, okay, in lead 1. So should you have a positive deflection or a negative deflection overall in lead 1? Positive, right? Good. And if it's negative, and we'll talk about this a little bit later, that's when you start getting right axis deviation. All right. So lead 2, like I said, I mean, that's kind of follows the normal conduction of the heart anyway and how it contracts. That's going to be the inferior surface of the left ventricle, because that's the furthest most, I guess, inferior portion of the heart. And then lead 3, also inferior surface of the left heart, even though it's kind of going towards the right side a little bit. For the most part, it's going down, right? So that's why 2, 3, and AVF, they're all on the bottom portions of your axis plane. They're all reading the inferior portions of the heart. That's why ST elevations in those leads are inferior MI.
So we put one with 4 leads on the right leg. Is lead 3 looking from the left to the right, or is it still looking at that electrode? We put 4 on there.
On the right is ground lead.
Right.
It is? Yeah.
Right.
Okay. Thank you.
So it's kind of a reference point for the machine, right? So it's not necessarily picking up. It's like when you're doing a 12 lead EKG, AVR doesn't really have a deflection. It's more of a reference point, even though it still picks up a waveform. It's not specific. It doesn't refer to any anatomical location in the heart. And I'm guessing that's the same way with the 4 lead. It's just a ground. It's just a reference point for the machine. So your limb leads. This is kind of a chart that just tells you where the positive deflection is going and then what surface of the heart. But even if you didn't want to memorize that chart, it makes sense, right? If you know where those leads are going, where those limb leads are placed on the body, then the furthest most surface of the heart with the positive deflection of that lead is going to be where anatomically the surface that it's picking up that portion of the surface of the heart. All right? So you can do it either way. Just thinking about it and going, well, 2 is going down to the left leg from the right arm. That's going to be inferior because that's where your positive or your current is going to be flowing. That's where your deflection is going to be at the most inferior portion. Lead 3 the same way. Lead 1, it's going from right shoulder to left shoulder, right? So that's going to be the most lateral, left lateral ventricle. All right, so your augmented limb leads. So this was the augmented voltage, and then you got right arm, left arm, and foot. What's that triangle called? Einthoven. Good. So AVR, fuse the heart from the right shoulder It doesn't view any, like I was telling you before, it doesn't view any anatomical location of the heart. AVL views the heart from the left shoulder. That because it's at that left shoulder and it's picking up the charge, it would be the lateral wall of the left ventricle, just like lead 1, right? Because of where it's placed. AVF, same, in the same respect. AVF is down in the left foot, so it's going to view the heart in the inferior surface of the left ventricle. All right. And then we talked about the frontal plane with those 6 leads, unipolar and bipolar. This is the horizontal plane. So this is your transverse section. And this is how it's viewing the heart. So you can get, based on these leads, you can tell if the injury is anterior, posterior, right, left, etc. Right?
How would you determine if it's posterior when you're looking mainly at an anterior?
So it depends on how the deflection is, right? So if you've got ST elevation in the anterior leads would be what do you think? Okay, mainly 2, 3, but yeah, it can certainly be 1 and 4 as well. So if you have, instead of significant ST elevation in those leads, you have significant ST depression in those leads, then that could mean ST elevation in the posterior leads. And that's generally, if we see significant ST elevation just in the anterior leads, that would be an indication, okay, let's get a right-sided EKG, let's get a posterior EKG and see what this looks like. You can also mirror it and then flip it upside down. So you take it and you mirror it and then flip it upside down. And depending on how you fold the paper, you can just turn the paper around and, however you want to orientate and then look at it. Like, well, that looks like a tombstone, or whatever. Then you know that that's posterior MI. Does that make sense? So you can still tell posterior from the anterior leads depending on what your morphology looks like. All right, so the precordial leads. You guys have probably heard medics talk about this, docs talk about this, cardiologists talk about this. So what do the precordial leads show? They're talking about these leads in the horizontal plane. Precordial leads are your V leads, V1 through 6.
So our question as far as the precordial leads, is that only we mainly use that looking for MIs? Because like toxicology stuff, we signed off lead 2, right?
You can. All of your leads are going to help with other. Your conduction systems or abnormalities you're going to see in precordial leads as well, like right bundle, left bundle branch blocks. You're going to see in the precordial leads. Your significant peaked T waves. You're going to see significantly in the precordial leads. You're going to see all sorts of different things. But yeah, you should be able to see them in your limb leads as well. Sometimes they're stronger in certain leads than others, depending on how it's affecting your depolarization.
And then the negative for the chest leads, is that the AVR or was it the back?
What do you mean the negative for the chest?
So those are the positive. Where's the signal? Oh, they are? Okay.
There you go. All right, so chest lead placement. So first you want to find the notch, so everybody can feel that notch on their own body. What is that notch? We call it the sternal notch, although technically that's the manubrium. And then from the notch, you go what? 2 fingers down, or you don't necessarily have to do 2 fingers down because everybody's anatomy is a little bit different. But you want to drag your finger down because the notch is easy to find. Basically, almost on anybody you can find that notch, right? Then you can kind of drag your finger down until you feel a little indentation, and that's the sternal-manubrial joint. That's when your actual sternum and your manubrium touch. So you got your notch right here, and it kind of does this thing. This is where your collarbone is coming off on each side of your chest, collarbone, and then that's this is called your manubrium, and then your sternum kind of comes down here into a tie-like looking thing. It's not a great drawing, but you're feeling that sternum-manubrial joint right there. My sternum broke when I was in the avalanche, so I have this huge notch. So it's separated by about 1.5 centimeters right there. I don't know if you can see it, but it looks really funny from the side. I got this big thing sticking out. So it would be really easy to find mine on an EKG. What's that? No, I have a buddy that every time he sees me, he rubs my knob.
That's a good friend. That's awesome.
Right.
Takes a real man to admit that.
I guess that does sound kind of weird. Every time he sees me, he rubs my knob. No, yeah. Right, exactly. Yeah. That's awesome. All right. From the sternal-manubrial joint, in some people, it's knobbish. So you follow the angle of Lewis. That's going to be your. You can I guess from there you can go over and find your second rib. All right, that's where your second rib is. You guys can kind of follow that over the rib that you're touching right there from that joint is your second rib, and then you can locate your second intercostal space, which is going to be just below your second rib, right? That second intercostal space, then you can go down to the third intercostal space, go down to the fourth intercostal space, and that's really where you want to be, is in that fourth intercostal space on the right side. Now, when you get good at it, and you start just looking at chests, I don't think very many techs or people are doing this thing and feeling and going down, although with some people you probably should, but not always. Oftentimes you're just looking at them and sticking the lead on. It's not the most accurate way to do it, but certainly works, I think, with experience. So that goes, which lead goes right there? V1. All right, good. And then after you've got V1, you can go over onto the left side to the corresponding intercostal space, and which lead goes there? 2. Good. And that's left of the sternum. From the V2 position, you can go down into the 5th intercostal space. So you just go down kind of over one rib and then follow that to the midclavicular line, which is generally going to be where the nipple is, but not always because everybody's different, right? But you want to be midclavicular. You guys know what I mean when I say midclavicular? You guys are doing needle decompressions. You know what midclavicular means, right? Right in the middle of the collarbone, midclavicular. All right, and that, which lead goes there? 4, good. So you got V1, V2, and then based on anatomy, you can correctly place V4, and then where does V3 go? Right in between it. You guys set up all of these, right? So you guys know how to do all this stuff. All right, so where's 6 going? Mid-axillary. Right, which space? The picture kind of distorts because it looks like it's a little bit lower, but it shouldn't be. It should be the same intercostal space, right? So it should still be which? 5th intercostal space. That mid-axillary, and then 5 goes right in between. So 4, 5, and 6 should all be in that 5th intercostal space. All right, so this gives you a good chart on which surface of the heart these precordial leads are seeing. So V1, that's your right side of the sternum you're picking up. And that's why they call it, septal leads. I think 2 and 3 are better septal leads, but in general, when you're reading EKGs, now for memorization's sake and for testing's sake, it's good to memorize the anatomical location. But from a clinical perspective, there's going to be overlap, right? Most of the time, you're going to have a septal anterior injury. It's not going to be just solely anterior. It's always going to be septal anterior, anterior lateral, right? Of course, it can certainly be focal. That would be a lot earlier in the disease process that you catch that. But most of the time, by the time we're seeing it, patients been dealing with this for hours and ignoring it and, whatever. And they finally call you, and then it's there's a lot more injury. So you're seeing it across different anatomical locations. So right chest leads, how do you think you set up the right chest? Exactly, you just mirror it, right? They go through the whole right chest lead placement. I don't think we need to go through all that. It's the exact same thing, just mirrored. So you can kind of imagine how that electricity is going through on a right chest lead versus a left chest lead, right? You just need to be able to label right chest EKG. That's going to be important, right? If the doc thinks that that's a left chest EKG, it's going to be different, at least in location of injury and whatnot. All right. So posterior chest leads. And, Josh obviously talked about this with his research study. But it's the same horizontal line as 4 and 5. So which intercostal space is it? 5th. And you're just following that around, right? Posterior axillary line for V7. V8 is that posterior scapular line. So it would be mid-clavicular, but on the backside, right? If you can kind of imagine. And then 9 is going to be paraspinal instead of parasternal. All right?
We don't have the capability of our machines to do that. Just use 4, 5, 6. You can't do a full 15 at a time. Take 3 of them.
Right.
Right.
Exactly. So you take, 4, 5, 6 and move them over 7, 8, 9. And just like Josh was saying, you just would then have to label on the EKG, physically cross out where it says 4, 5, 6, cross those out and write in 7, 8, 9. All right. And then up at the top right-hand corner, you would write posterior EKG. So everybody knows what you're looking at. There's your lead placement.
question.
posterior
They
chest.
show, and they say lay the patient on the right side or whatever, but when you went to capture that, you'd want them sitting in the same position that you had for your prior reading, correct? So that heart's in the same place.
Right. So yeah, you can roll them over to get their put the lead placement on, and depending on how comfortable they are, yeah, roll them back over and get the right reading when you actually print out the EKG. All right. So I mean, this is kind of just a trying to imagine the positive electrode, and that you're imagining that's where your heart is looking at, or that's where you're looking at the heart. It's where that positive electrode is. So that's where the surface of the heart that lead shows is where you're going to be looking at the heart, where that lead is. We talked about this a little bit on conceptually, just figuring out which surface of the heart those leads are picking up because of that direction. But the book kind of suggests just imagine yourself from that lead, then looking at the heart. That's the surface that it's picking up. And this is just going through different examples. Which leads are these? They don't have the leads placed all that well because there's not a whole lot of space there, but that's generally would be what? Because which one is midclavicular?
3, 4.
4, so that would be 3 and 4, right? That would be what? 1 and 2. Good. All right, so surface of the heart viewed. So 2, 3 and AVF, inferior, right? That's where your inferior MIs are going to be seen in 2, 3 and AVF. V1 and V2 is your septal MIs. 3 and 4 is anterior. We often just generalize those in the septal anterior because very rarely do we see them so focal that they're not in both. Then you've got your lateral. Now the lateral can be broken up. We'll see it in 5 and 6, sometimes 4, 5, and 6 if it's anterior lateral. But that can be different blood supplies. So you can have a pure lateral where it's going to be 1 AVL, 5 and 6, and that would be where do you think that occlusion is in the circulation of the heart? If you're seeing it in all of those leads, where's the occlusion? Proximal LAD, so main LAD. So before it branches off into circumflex, right? And left anterior. So that would be proximal LAD occlusion, or you'd say main, where it catches all of it. If it's just circumflex, what do you think you would see? Which leads? Just circumflex is 1 AVL and 6, sometimes 6. I would say most of the time 6. And that's a circumflex injury, 1 AVL and 6. Does that make sense of why you would see that? Because which direction is circumflex going? It's going across the heart. So it's going to show up in those leads that are going really right to left, right? So that's going to be 1 AVL, and then sometimes you'll see it in 6, because 6 is kind of the most lateral.
So 1 and 6 means the circumflex, and then
1 in AVL and 6, sometimes 6.
1 AVL and 6 is the circumflex.
Circumflex, yeah.
Which one was the LA?
Anterior descending is generally 5 and 6. But if you have a main occlusion where it's blocking both circumflex and left anterior descending, then you're going to have all of them. Right? And sometimes, you know, you're going to have anterior as well. That's why often we'll see 3 and 4 with it, and that'll be a big occlusion, right? You're taking out a lot. So if you're taking out LAD proximally, then that's going to take out the septum as well, right? So you're going to have an anterior lateral. Just from a clinical standpoint, and I guess you guys don't have to memorize this, at least I'm not seeing it anywhere in any of your information that you guys have to memorize this, but it's definitely good to know from a clinical standpoint. Sometimes you'll have normal looking waveforms in all of your leads except AVR. Now, AVR does not correlate with any specific location of the heart, right? It doesn't match with any anatomy or specific surface of the heart. But if you have a significant ST deflection in AVR and normal in everywhere else, that's an indication for a severe proximal occlusion, okay, main LAD. That's just not showing up as muscle injury yet, but that it's an indication of a severe occlusion, just very proximally. So you guys, I mean, we've been over EKG paper. I don't think we need to go through all these boxes. You guys have been doing this forever, right? You guys understand the math of the boxes, what it all correlates with. So as we're going across, that's milliseconds. Up, amplitude is volts. How many millivolts, or I should say, what's the conversion of millivolts to milliliters or millimeters? One what? Millivolt per 10 millimeters. 10 small boxes. All right, good. Did you guys ever notice that box, that calibration in the beginning of all those EKGs? Have you started to pick those up? Or seeing that? Yeah, that box. You see those boxes in the beginning of all those? That gives you your calibration. So if that's off, you know that none of your math is going to work out from an amplitude standpoint. It means that your machine's not calibrated right. All right, so format of a 12-lead EKG. This is what we talked about before. So you've got 1 AVL and 6. And generally when I'm looking at an EKG paper, I kind of circle, at least when I was learning this in your guys' stage, I would circle this kind of horizontal circle, that's circumflex. You know, this is lateral, this is anterior, this is inferior, so that, you know, when I'm thinking about it, I can remember where on that EKG that was. And that's just from a pure memorization standpoint. Now, conceptually, if you know where all the leads are placed on the body, then you can figure out which parts of the heart would be injured by those leads, right? All right. I don't know if this is necessarily telling us a whole lot, but how many seconds is each lead on an EKG that you're seeing? So time from here to here, and here to here. 2.5 seconds. So you're seeing a 2.5 second view. Sometimes that's not long enough to see a good rhythm, and that's why they give you more of a strip on the bottom, and you can tell the machine which lead you want to have that strip on the bottom, right? If you want that to be lead 2, if you want that to be lead 1, whatever. But you can also, even though it's different leads, it's continued, right? So you can still match up and count off your rate across leads on an EKG paper. Does that make sense?
So, first beat on lead 1 is not the same as the first beat in APR, or are they not exactly the same?
It's the exact same beat.
Yeah.
Yeah. It's just a different view, but it's the exact same
We're
view.
looking at 5 beats and just from different angles.
Yep. So how many different views do you have there? 12. 12 lead EKG. Who'd have thunk, right? All right, so those are your limb leads. Over there on the left, your precordial leads or your chest leads. Over there on the right, this gives you a depiction of where your anatomy on the heart. Your no man's land is over there in ABR. All right, so this is kind of a review of what stuff that you guys already know when we talked about rhythms and leads. So you guys know all of these terms. We talked about this deflection and how depolarization gives you either a positive, negative, or an isodeflection depending on where the leads are, what part of the heart. We talked about the P wave represents the atrial depolarization and the spread of the impulse through the right, or from the right to left atria. That bottom part, or I should say the second half of the P wave is your left. So you're going to have, P waves can look differently in different, depending on the disease criteria. In general, more peaked P waves is a problem with the right atria. Wider P waves is a problem with the left atria. So it can start to tell you if there's right strain, left strain, yada yada.
So PP is the right, longer is the left.
In general, sometimes different diseases can give you different waveforms of for P waves, but in general, your taller P waves, your abnormally taller P waves, is going to be a problem with the right atria. Wide P waves can be a problem with the left atria. So QRS should be following each P wave. Q wave we talked about is that first deflection or negative deflection. If you only have a large negative deflection, what is that? Okay, it is an S wave. You can also call it a QS wave. All right. So it talks about the Q wave again. We had this on previous lecture. Your Q wave normally should be 1 box. If it's larger than 1 box, that's pathologic. If it's deeper than 1/3 of your R wave, that's pathologic as well. That usually indicates older MI. All right. So if they have new abnormal Q waves, then they probably need to be checked out a little bit closer. Either by probably not stress testing, but a cardiologist probably cath them. Might not be an emergent cath, but probably needs to be cathed because there is lack of blood flow and an issue there. So R wave is always the positive deflection. S wave is always a negative deflection. This is why you've got the positive amplitude in 1, 2, and 3. We have been over this stuff. Normal QS duration, 0.11. You get different QRS variations. So you have QS waves, just all negative deflection. QR, still a QR. QR when the Q is pretty big. Got a normal QRS there at the end. R wave, then you can have an RSR prime if you've got 2 R waves, yada yada. We've talked about that too. All right. So yeah, this is kind of a clarification of things that we've talked about as well. There's a purely negative deflection, that's a QS wave. If there's only a positive deflection, that's an R wave. But that's still where the QRS begins, right? We've got R primes and S primes. It's very rare that you find an S prime. So your chest leads and a normal heart. And this is called R wave progression. As you're seeing from V1, 2, 3, you've got almost purely negative, then it becomes more ISO, then it starts to become more positive deflected. That's called R wave progression. All right, where you've got just a little R wave, and then it's getting bigger and bigger. If you have poor R wave progression, that can be a sign, more of a subtle sign that the patient has coronary artery disease. Not necessarily having an MI, but has disease and will have an MI if it's not fixed. So that transitional zone should be around 3 and 4. You have poor R wave progression when 3 is still negative, 4 is negative, a little bit closer to ISO, and then 5 is more ISO and finally becomes positive. It's just a much slower progression where it's not happening as soon as it should, that transitional zone. Does that make sense? So this is an example of poor R wave progression. V3 is still very negative, where it should be more of an ISO amplitude, right? V4 still negative, where it should start to be positive. 5 finally starts to be more ISO. 6 is the only time where it starts to become positive. So that's poor R wave progression, indication of disease. And where do you think that disease is? You would say anterior lateral. So that would be further up. It would be more proximal, LAD, or maybe main, depending on what your circumflex leads look like. So you guys know about T wave, represents repolarization. You can have a lot of different looking T waves, right?
So we'll go back. I'm sorry, back to the, yeah, that's probably a situation where you want to put on 7, 8, 9 to see if you've got reciprocal.
No, not necessarily. You could certainly get a posterior EKG. You probably wouldn't. We wouldn't necessarily jump to a posterior in the hospital, although I think it would be beneficial and give added information. And based on newer research, we should be doing more. So if you're seeing disease in those locations, but this would be more of an anterior lateral disease, so not necessarily posterior disease, but you could certainly see, because which blood supply feeds posterior? So in which blood supply feeds posterior? Circumflex does some posterior, RCA does.
That's right.
Does mostly,
That's right.
right? So your posteriors are going to be mostly correlated with inferior MIs. Now, you can get a hint of posterior MIs when you see abnormalities just anterior leads, okay? Because it'll have a flipped look like what we talked about, right? If it's purely posterior. All right, so T wave, you guys know about T waves. So your amplitude of T waves is going to be most pronounced, or it should be in 2 and 3. That repolarization. And why do you think that is? Where's 2 and 3? Left peristernal. So where is that in relation to your heart? 2 and 3. It's kind of, yeah, right on top of it. So as the heart is repolarizing, all those muscles are repolarizing, you're going to get that positive deflection in those 2 leads. If you've got peaked T waves like you're seeing there on the right side, what's that? Hyperkalemia. If you've got low amplitude T waves, that could be an indication of low potassium or magnesium.
So it's not considered significant unless it's over 10 small squares or big ones.
Oh, for the peaking?
Yeah, when it's considered.
Sometimes it's dependent. That's a general rule when you're looking at an EKG on a person for the first time.
Okay.
But it oftentimes it can also be in relation to what their old EKGs look like, because everybody's is going to be a little bit different depending on what disease they have. They have hyperkalemia, likely they already have disease. They have, kidney problems. They're diabetic. They're on DIG, whatever that would be causing hyperkalemia. So everybody's normal EKG is going to look different anyway. But yeah, that's a general rule for your PTs.
I know Trevor, you've already answered any questions. Need more. So the PT wave, is that because there's so much potassium in the system that it just rushes in the cells too fast, or what causes it?
So with hyper K, you guys remember where your ions will be from a cellular perspective with depolarization and repolarization. So where should your potassium be in repolarization?
Be outside the cell.
Outside the cell. And if you already have too much potassium outside of the cell, you're having from an ion perspective, I don't know if conceptually it necessarily makes sense. Your broad T waves would be more of a delay in repolarization. Your peaked T's before your heart is toxic, right? If it becomes too much, then there's no movement. But if you've got already a lot of potassium, it's not necessarily dependent on the shift, but more the positive to electric charge, because if there's already too much potassium outside of the cell, then that'll give you a higher amplitude because there's more of a positive charge. Does that make sense? Probably not. We'll look at it when we'll talk about action potentials a little bit in a later lecture, and you guys will be able to see how the charges change intracellular and extracellular. All right. U waves. You guys know what the U waves look like. From a testing perspective, a U wave is nice to know just so you don't get confused with a P wave or something else. But in a clinical perspective, you're really not going to be commenting on U waves very often. It's just useful so that you don't get confused with something else. And then segments, you guys know about your segments. You guys know the difference between segments and intervals, right? You guys understand J-point, correct? All right. segment elevation, what could be normal, and what definitely is not normal. However, if you get any kind of ST segment elevation, you want to further investigate, right? That's an MI until proven otherwise. So ST depression more than half a box in 2 and 3, or more than 1 millimeter in the other leads. So 2 and 3, it'll be a little bit more sensitive. And then of course you get your dig dip scoops giving ST depression. You guys understand intervals. You guys know where all your intervals, right? PR interval, beginning of the P to the onset of the depolarization or any part of that QRS complex. Wide PR interval is more than 0.2. You guys know that. RR intervals is for your rate. And all right, so axis deviation. This has to do with the vectors, and this is why when you're looking at axis deviation, what are the two quickest ways to, or the two leads where you can get your quickest information for axis deviation? 1 and AVF. All right, so if 1 is up and AVF is down, that's left axis deviation, correct. And the opposite is right axis deviation. So what's this thumb up, thumb? Is that how you remember it?
That's how my medic taught me. So you just take it. So lead 1 and AVF. So if this one's up and AVF is down, you got left axis.
So you just got left hand, right hand?
Yeah, you just left hand, right hand every single time. It's just street medicine.
I like it. Street medicine. That's what we learn on the street.
It's super easy, guys.
I was told that if they're playing away from each other, they just left each other. They don't want each other to run right towards each other.
I don't know. Whatever you like, Alex. I don't know. I just 1 and AVF. Follow there.
So,
what is the thumbs up, down?
So left hand.
Here, come up to the front of the class. Go like this.
Yeah.
Okay, so. Hi, my name's Christina. Okay. Search for AMR. Okay, so left hand is lead 1, right hand is AVF, always, right? So if it's positive deflection in lead 1 and negative deflection, so the QRS is pointing down in AVF, you have left axis deviation. If lead 1 is down and the QRS is up in AVF, then you have right axis deviation. If they're both up, then it's normal. If they're both down, then it's just crazy.
Yeah.
So super easy. I mean, just always do it like that. I mean, I call it the thumb wrong. You can't.
It's the Fonzie 12 lead.
Fonzie.
So you can always just tell axis just like that. Super easy.
Thank you, Christina. So, question.
What do we do with
If
that?
heaven forbid I encounter another farming accident and I don't have a thumb,
Just start
Well, then
using
you-
your fingers.
Well, then you can see it. You'll start seeing it right away on the sheet as you do it more and more. So, yeah, just use your arms. Thank you, Josh. Yeah.
so use the 1 AVF.
Yeah, it's always 1 and AVF, and then you'll just start seeing it
How do
more
I
and more.
remember that though?
Now in the field, what do we do with axis deviation? Nothing?
No, what does axis deviation tell you? If you have right axis deviation,
Halfway, pass them off big and one, one big one. That your signal's predominantly moving forward, right?
so right axis deviation is one of those hints that can tell you, or can tell you that there's right heart strain. I mean, you can also look at P waves, you can look at some other waveform stuff as well, but axis deviation is like one of the first things that can hint towards that. So if you have significant right axis deviation, then that means that there is more of a depolarization on the right side. There's a strain on the right side. Muscle is building up on the right side, or it's just working harder on the right side, so you're getting more electrical activity over there. So you've got right heart strain. And what's right heart strain? What's the big, bad, ugly with right heart strain? PE. Yeah. I mean, that's the emergent big, bad, ugly. You can get right heart strain with any kind of lung disease, right? But the big bad is going to be your PE. Now, there's other stuff with PE on your EKG that we won't go into right now. I don't know if you guys will learn later or not, but
Are there any big bad things with left deviation?
yeah, if you get a left axis deviation, that means that you've got increased on the left side, right? So that's going to be indication. LVH. I mean, LVH can be a mimicker of different pathology as well. You're going, well, is that LVH or is that electrolyte abnormality or whatever? And then, I mean, left axis deviation is just indication of heart disease in general. Yeah, I mean, it could be CHF, could be hypertension, could be, patient has got probably coronary artery disease, but their heart has to work harder. So your mean vector, where is your mean vector in the heart? Meaning the overall amplitude or the overall vector, all of the, I guess, leads combined or whatever. Should be this way, right? That's your overall vector. And that's why when you're drawing your axis, that's how you can tell if it's left heart strain or right heart strain, right? You've got AVL here. If AVL is not positively deflected and it's negatively deflected, well then that leads vector is now going this way, which will move your overall mean vector a little bit further this way, right? So it becomes deviated to the left axis deviation. Oppositely, right axis deviation.
You said downward and to the left is left. Is that right axis deviation?
Yes.
Okay.
Right axis deviation, left axis deviation. Sorry. Yes, you're right. Or you're correct. So this is Eindhoven's triangle again for lead 1, 2, and 3. It's just a reference system. And you have your augmented limb leads in there as well. And then this gives you the rest of your frontal plane leads with axis. So this gives you your vector, and your overall vector really is following lead 2, right? And depending on where your axis deviation is, all right, so determining electrical axis. What are we looking at here? Yeah, it looks pretty normal, right? The AVL has kind of crappy amplitude there, but I think this is actually the exact same one. So yes, normal sinus, normal EKG. So your normal QRS axis, we talked about that between -30 and +90, just on that axis grid. So your right axis deviation is going to be between 90 and 180 right here. right? The overall vector will change to here. That'll be right axis deviation. Overall vector change more up here. This will be left axis deviation. That's basically what these slides are telling you. It's just telling you the degrees. Right? 0 degrees, 90 degrees, 180. So between 90 and 180 is right axis. Between 0 and, I mean, you could say negative 90, or you could say between 30 and 90. All right, so this is basically what we talked about. Might give you a little bit more succinct definition, but so your leads 1, an AVF will divide the heart into the 4 quadrants, and that's why those are the 2 leads that we're really looking at for axis deviation. Since we already talked about this with a wonderful thumb trick, you can either do the thumb trick, or you can memorize this chart, or you can think about it conceptually.
So the way the vector is going, is showing what's causing more electricity after fractal.
Yep, with depolarization, where most of your current is being recorded, because your current is all going from right atrium to right or left ventricle, generally, right, as it's moving along. Plus, your left ventricle is the strongest, most powerful, most muscle mass. So you're going to have most of your polarization in the left ventricle anyway. So yeah, it's going to move that way.
You're saying
If the right heart starts to get beefier because there's strain and it has to pump harder into the lungs because there's lung disease, there's atrial atresia, there's a PE that's blocking blood flow, then the right heart starts to become beefier and stronger, has to contract harder on the right side, and so that vector starts to change. You get more amplitude going, starts to go this way, and then it starts to, kind of go towards the right side of the heart. All right? We understand vectors? You guys seen Despicable Me 1? Vector.
Oh, yeah.
oh, yeah.
That guy's awesome. I can't remember his line.